Welcome to Board Pearls. This is episode 1 of 3 of the esophageal symptoms and diagnostic workup chapter in the esophageal disorders module. This episode is the workup of dysphagia, and the encouraging thing about it is that 2 questions asked at the bedside settle almost everything before you order a single test. Where does the food get stuck, and what gets stuck and when? Answer those 2 and the right test picks itself, so the whole skill is learning why each answer points where it does. Take the first question, where? When the trouble is up at the throat, at the very moment the patient tries to swallow, the problem is in starting the swallow and getting the food from the mouth into the esophagus. When the trouble is lower, behind the breastbone, and the food sticks a moment after the swallow is already underway, the problem is in moving the food down the esophagus itself. That single split, throat versus lower chest, separates 2 completely different diseases with 2 different tests, so it's the first thing you pin down. The second question, what and when, does even more work, and it works because of a mechanical fact worth understanding rather than memorizing. A physical narrowing blocks solid food first and lets liquid slip past until very late, because a solid needs a channel wide enough to pass, while liquid gets through a tight spot for a long time. A failed muscle wave, on the other hand, fails on everything from the start, because a wave that can't organize itself can't push liquid any better than it pushes solid. So solids first, then eventually liquids, tells you something is narrowing, and solids and liquids together from day 1 tells you the muscle is failing. And then the tempo separates further. Trouble that comes and goes over years is a benign, fixed narrowing, while trouble that marches steadily worse over weeks to months is the pattern that makes you think cancer. Go back to the throat group first, because it's mechanically distinct. Trouble starting the swallow shows up as airway trouble, and that's the giveaway, because starting a swallow is largely about protecting the airway while the food goes the right way. So these patients cough right as they swallow, because the airway isn't sealed. They bring liquid up through the nose when the soft palate doesn't close, they drool when the mouth can't hold the food, and they aspirate when food reaches the airway before the larynx lifts and shuts. Almost all of this is a nerve and muscle problem, so the causes are the neuromuscular ones, stroke and Parkinson most commonly, with ALS, myasthenia gravis, and prior head and neck radiation on the same list. The one structural exception here is a Zenker diverticulum, which we'll come to because it needs special handling. The test for the throat group is the modified barium swallow, the one done with a speech therapist watching by fluoroscopy, as the patient swallows different consistencies with the head in different positions. And the reason it's the right test rather than endoscopy is the whole point. This test watches the act of swallowing itself, whether the food stays controlled and whether the airway is protected, and it lets the therapist see whether a simple maneuver like tucking the chin turns an unsafe swallow into a safe one. Endoscopy only looks at the lining. It can't see a patient aspirate, and it can't tell you whether a head position helps, so it's the wrong tool for a swallowing mechanics problem. The speech therapist isn't an add-on to the test, they are part of what makes it the test. Now the lower chest group, where the pattern you already took from the history carries most of the diagnosis before any scope. Solids only, slowly getting worse over months, going from bread and dry meat down to softer foods, means the channel is narrowing, and that list is a Schatzky ring or a web, a peptic stricture, eosinophilic esophagitis, and the one that sets the urgency, cancer. Solids and liquids together from the start means the muscle wave is failing on every swallow, and that list is achalasia, spasm, the too strong jackhammer esophagus, and scleroderma. A couple of histories are worth recognizing on sound alone. Intermittent sticking on solids over years, the hurried bite of steak that lodges and then passes, is a Schatzky ring. And steady, worsening trouble with solids over a few months in an older patient who's losing weight is esophageal cancer until you've proven otherwise. For that lower chest group, the first test is endoscopy with biopsies, and it earns the spot because in one pass it looks for the rings, strictures, and cancer, and it takes the biopsies that catch eosinophilic esophagitis. Take those biopsies high and low even when the lining looks completely normal, and here's why that matters. Eosinophilic esophagitis is diagnosed under the microscope, and the esophagus looks normal to the eye in up to a third of cases, so a scope that looks clean but skips biopsies misses the diagnosis in exactly the patient most likely to have it. A barium swallow comes in when the scope doesn't give an answer, and a ring, stricture, or motility problem is still in play, or when the history already pointed at a muscle problem and you want to see the column move. And manometry, the pressure study, is the test when the muscle is the leading suspect, because it's what actually makes a motility diagnosis, and going to a myotomy or a dilation without it is a real error, since the specific type of achalasia changes which procedure the patient needs. Now the part where careful test takers talk themselves into the wrong answer. The alarm features. People memorize a list: age over 50, weight loss, iron deficiency anemia, GI bleeding, progressive solid dysphagia, persistent vomiting, and then try to apply it to a dysphagia patient by asking whether they cross some threshold before scoping. That's the mistake, and it lives at the age cutoff. Age over 50 is an alarm feature for dyspepsia, not for dysphagia. In dyspepsia, you're deciding between just treating with a PPI and testing for H. pylori versus scoping, and that's the decision age and alarm features are meant to settle. Dysphagia is a different situation entirely, because new difficulty swallowing is itself an alarm symptom, so the decision to scope is already made just by the symptom being there. A 35-year-old with new solid food dysphagia gets endoscopy, and being under 50 buys them nothing. What the alarm features actually do in a dysphagia patient is raise the odds that the cause is cancer specifically, which changes how urgently you move and what the endoscopist is set up to do, so progressive solid dysphagia in a 65-year-old smoker losing weight turns a routine scope with biopsies into a scope ready to stage a tumor the moment one is found. Zenker diverticulum is the reason there's an exception to leading with endoscopy, so it's worth a minute. It's a pouch of only the inner layers of the wall, no muscle, that pushes out the back of the throat through a weak spot called Killian triangle, the gap between the muscle fibers above and the cricopharyngeus below. It forms because the upper sphincter doesn't open properly, so years of swallowing drive pressure into that weak point until it balloons out. These are mostly older patients, and the history that hands you the diagnosis is bringing up undigested food eaten hours or even days earlier, along with bad breath from the trapped material and a gurgling sound with swallowing, and eventually cough and pneumonia from spilling into the airway. You diagnose it with a barium swallow, which fills and outlines the pouch, and you specifically avoid leading with endoscopy because the scope tip can slip into the pouch instead of the real channel and tear it. The fix is cutting the cricopharyngeus muscle and dealing with the pouch, done either open or through the mouth with a stapler that divides the wall between pouch and esophagus in one go, or endoscopically by cutting the muscle through a tunnel under the lining. The patient who ties this together is the one whose scope doesn't settle it. A 55-year-old woman, a year of worsening trouble with both solids and liquids, bringing up undigested food, coughing at night, losing weight. The pattern says muscle, and achalasia is the frontrunner. The scope is done first and shows a dilated esophagus with food sitting in it, and a junction that opens with gentle pressure, no mass, no ring, normal biopsies. The story is so classic that it's tempting to go straight to a myotomy, and that's the wrong move, for two reasons. First, the pressure study is still needed because the type of achalasia decides the procedure. No contractions at all is type 1, whole-length pressurization is type 2, and premature spastic contractions are type 3, which leans toward the endoscopic myotomy, precisely because the cut has to be made long enough to cover the spastic segment. Second, a tumor at the junction can imitate this whole picture, so you confirm before you cut. And if the pressure study comes back borderline, with the relaxation number just over the line and no clear pattern, it's officially inconclusive, and the right next step is a confirmatory test, the imaging probe at sedated endoscopy or a timed barium swallow, not the operating room. So the whole thing comes down to a few moves. Find out where. Throat with airway symptoms goes to the modified barium swallow with a speech therapist. Lower chest sticking goes to endoscopy with biopsies. Then read the pattern in the lower chest group. Solids only and worsening means a narrowing, and the scope is hunting for a ring, stricture, eosinophilic esophagitis, or cancer, while solids and liquids from the start means muscle, and the scope is just the look before the pressure study. Treat new dysphagia as its own alarm symptom and don't borrow the dyspepsia age cutoff for it. Add barium when the scope is unrevealing or muscle is suspected. Add the pressure study when muscle is the leading idea. And recognize Zenker from the history so you lead with barium and don't put a scope through the pouch. You never memorize which test to order. It falls out of those two bedside questions. That's the symptom that drives the chapter and the workup behind it. The next two episodes take the other esophageal symptoms that share the same anatomy but behave differently. Episode 2 covers the functional and behavioral ones, globus, rumination, and functional chest pain, plus odynophagia sorted by what the patient was exposed to. Episode 3 covers the dysphagias that come after surgery or from a systemic disease, the ones the standard workup misses when you run it on autopilot. For the full chapter, the practice vignettes, and the topic tag question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 1 of 3 of chapter 1, and I'll see you in the next one.